The American Society of Hematology, or what we call ASH, is really the largest meeting in the world of hematologists, coming together every December. This year, roughly 30,000 individuals, talking about every aspect of every blood disease. And it's really the annual accounting for in terms of research, progress, new treatment initiatives across all diseases, and in particular, myeloproliferative neoplasms. Now here, there are many things for us to really be very excited about this year in terms of some key updates. One, we continue to see new therapies being developed across ET, polycythemia vera, myelofibrosis, and even a whole range of less common myeloproliferative neoplasms, such as systemic mastocytosis, chronic neutrophilic leukemia, and other diseases that are we could consider them like cousins of PV, ET, and myelofibrosis. In ET, we continue to see increased information about new drugs being developed. One, further data as it relates to the use of long-acting interferons, and long-acting interferons are currently in phase 3 trials globally for ET, particularly with rho-pegylated interferon alpha 2B, currently approved in polycythemia vera as Bezremi. Second, in polycythemia vera, there's a new class of medications, and we have further updates on a medication that's currently in phase 3 trials called rusfertide. This is an agent that is trying to help individuals become independent of the need for phlebotomy and works in a slightly different way than medicines we've had in the past. It is what we call a hepcidin mimetic. That's a medical term for saying that it increases something called hepcidin that convinces the body that it needs to make less red blood cells and can replace phlebotomies. Why this could be helpful is it could, one, free people up from the hassle of receiving phlebotomies. Two, we've learned many patients who are receiving phlebotomies probably don't receive enough phlebotomies. And three, it may allow for more even control of the blood counts than phlebotomies, where the blood counts are going up and down in a serial basis. Additionally, there's data from the use of ruxolitinib in a frontline setting. What that means, ruxolitinib is one of our approved agents for polycythemia vera, but has been approved in individuals that have previously been on hydroxyurea and did not have an adequate response, had too many side effects, etc. In this ongoing study, they are treating patients who've been newly diagnosed with polycythemia vera and comparing them between ruxolitinib and best alternative therapies to gauge the overall impact of therapy for P. vera. Indeed, the consequence of this and other studies that are going on with interferon, we may increasingly move from just phlebotomy and aspirin for P. vera, but to really start using medical therapy earlier to try to better control the disease. Now, there are many trials here that are being discussed as it relates to myelofibrosis. Myelofibrosis can be one of the most problematic of the myeloproliferative neoplasms, and we now have 4 FDA-approved therapies. Ruxolitinib approved in 2011, Bedradin in 2019, pacritinib in 2021, and then now most recently in September of 2023, momelotinib. Momelotinib, we have many different data that are being presented at this meeting. I'm presenting several of these as it relates to best understanding the impact of momelotinib to improve spleen symptoms and anemia. Patients are less likely to need transfusions if they go on momelotinib, improving baseline anemia, or being less likely to have new anemia occur as a result of medical therapy. Now, the greatest excitement at the meeting, I would say, are around the phase 3 clinical trials with combination therapy. And there are 2 that are being reported. First, navitoclax plus ruxolitinib versus ruxolitinib alone. And second, ruxolitinib plus pelabresib versus ruxolitinib alone. Phase 3 trials are the definitive trials that can lead to a drug being FDA approved. In both of these trials, we saw that the combination of 2 drugs was almost twice as effective for reducing the size of the spleen than ruxolitinib alone. And this is really a major advance. We believe that that degree of reduction of the spleen may have important implications for long-term control of the disease, more durable responses, or perhaps help patients live longer or better. Secondly, there is additional data in terms of improvement in anemia, good safety profiles, similar or slightly better improvement in symptoms that suggest that combinations may play an increasingly important role in the near future for patients with myelofibrosis. And there are other phase 3 trials which are currently ongoing. So I hope that this message leaves you really with a sense of hope at the end of this 2023. New therapies, new things that are being developed, new understandings of the disease, right? And hopefully ways that we can better control MPNs. Longer term, there's tremendous excitement here. Outside of the MPN world, during this meeting, there was the approval of the first gene therapy for sickle cell disease using a technology called CRISPR. And although this does not have immediate implications for MPNs, it does potentially have long-term implications. As the first approved gene therapy, it further opens the door to see with MPNs that are diseases with genetic drivers being important in their cause, whether we can find ways to repair those genes and lead to more durable, more effective control of those diseases. So many exciting things ongoing, many important clinical trials. If your doctor discusses a clinical trial with you and you are eligible for a trial, certainly do give that important consideration. It's through clinical trials that we make advances. It's through clinical trials that new options are available that may benefit yourself as well as others that face the disease. So a note of both good health and peace for the new year. Thank you.